Good afternoon. Thank you so much for coming this afternoon. I hope the conference has been going very well for you so far. My name is Angela Amato. I work at the Institute on Community Integration at the University of Minnesota, and I am moderating this town hall this afternoon. So basically that means I have to keep people on track with the timelines. Right? So this particular town hall, actually Tash set up, if you haven't recognized this already in the program, Tash set up 4 town halls. This is the first time that they've done this as part of the conference. So there was one this morning about education, and there's 2 tomorrow. One is on employment, and I forgot what the other one is. Transition. So transition in the morning, and there's an employment one in the afternoon. So it's a wonderful opportunity to be here in Washington, D.C. in terms of people who represent various offices and accountabilities in the federal government to be able to engage in dialogue with us. So that was what the town halls were set up as. So this particular one is about life in the community. And the title of it, if you read it in your program, was Balancing Rules and Regulations with Individualized Supports. That is a work in progress. So the town hall participants will explore how to find the balance between, so we know that rules and regulations and requirements can be a quite powerful force for change. But that a balance is required between those with providing individualized supports to people who are finding their way for a fulfilling life. And the purpose of this town hall session is to work on finding common ground, understanding and opening up discussions about these 2 perspectives on supporting people with developmental disabilities or intellectual disabilities. So there's a couple of, there's tension between, there can be tension between those 2 forces of rules, regulations, and requirements, as with kind of the spirit and the heart and the passion regarding people having lives that are supported in the best ways possible. Last year, at last year's TASH conference in our gathering, if any of you were at our gathering, for example, we looked at 2 terms. We looked at the term person-centered, and we looked at the term community. And we had a very lively discussion about those 2 terms and the variety of things that they mean, how some people are twisting or distorting or abusing those particular terms, that people are using those terms for things that aren't necessarily true to the spirit of those terms. We know that those terms are hard to measure or challenging to measure, as well as the term inclusion. I mean, so many different things to people. So the purpose of this town hall is really, how can we use the guidelines and directions? How can we come together on how we can work together to make sure that people have good lives? So I do want to say also that this session is being recorded, so we will have a chance for people to ask questions or to make comments. But if you don't want to be recorded, don't make comments or questions. So I'm going to say the format in which we're going to work. We have 3 particular questions, and we're going to spend half an hour on each question. And then we'll have hopefully 20 to 30 minutes at the end for a more open discussion about other topics that people may want to bring up or ask about. And we have 4 federal panelists. I'm going to introduce our federal panelists. And the first one here is Eve Hill, who's the Deputy Assistant Attorney General for Civil Rights at the U.S. Department of Justice. And then we have Sue Swenson sitting next to her, who's the Deputy Assistant Secretary, the Office of Special Education and Rehabilitative Services. And next to her we have Sharon Lewis, who's the Principal Deputy Administrator for the Administration for Community Living. And on the end we have Ralph Lawler, who's the Director of Long-Term Services and Supports with the Centers for Medicaid and Medicare Services. Did I get all those right? Everybody's right. Good. So, just in case anybody's title changed in the last day or two. So, Okay, and so I'm going to just tell you what the 3 questions are at the beginning, so you have a sense of what kind of discussion we're going to have today, and then I'm going to come back to the first question and tell you a little bit more about the format. So the first question is, how will the home and community-based services waiver regulations be implemented to ensure that they live up to the promise of the Olmstead decision? The second question is, how can support recipients, families, and their allies be best supported by state agencies to get what they need to live the lives that they want? And the third question is regarding abuse, neglect, and fraud. Are concerns for these 3 issues overpowering good practice? So with each of those questions, we have 2 or 3 different representatives of TASH and representatives of their own agencies and perspectives from different states. With each of the questions, we're going to have 2 or 3 representatives make comments about this question. Some of them might include questions for our federal representatives, and so each of them will speak about 2 or 3 minutes with those perspectives, and then we'll hear from our 4 federal panelists, and if we have time in that half-hour time frame for each of the 3 questions, we'll can have some other questions or comments from people. Okay? Any question about the format, or everybody clear about that? All right, so the first question, I hope everyone knows the Olmstead decision in terms of different requirements by the Supreme Court for people being served in least restrictive environments, for example, and then there's new home and community-based services waiver regulations to be implemented, with the states making transition plans in the next 5 years or so to actually implement these new regulations. So how will the HCBS waiver regulations be implemented to ensure that they live up to the promise of the Olmstead decision? And the first person we have addressing that is Gail Fanjoy, who is the CEO of KFI, which is an agency in Maine, and also on the TASH board, I think, yes?
Thank you, Angela. Good afternoon. Well, I think my question's going to take 2 minutes, so I'm just, it's long, bear with me. The HCBS waiver regulations regarding the new settings rule have the potential to significantly change the lives of people with disabilities in terms of how they live, how they spend their daytimes, their opportunity for meaningful employment, and choice and control over their environments and the people in them. But much depends upon how the language in the regulations is defined and interpreted. As Angela said, we've seen words like community, person-centered, home, and inclusion, just to name a few, become interpreted by well-meaning people and systems that end up being totally unrecognizable from their original intent. We cannot rely on those words alone. In order for people with disabilities who find themselves in isolating congregate settings to realize the promise of Olmstead, we must make it clear to those who harbor and incarcerate them in homes not their own, in buildings and programs exclusive of typical citizens and valued activities, and in workplaces that don't match their skills and abilities and earn them pennies on the dollar, that this new regulation signals a new day. My question is, what words can those who wrote the regulations with all good intention use? And what actions can those whose job it is to partner with or enforce the regulations with fidelity take to ensure the spirit and boldness of the regulations transforms the lives of those held captive by a service system to ultimately achieve freedom of association, freedom to decide a personalized daily rhythm and routine, and freedom from poverty through the provision of personalized and customized supports, both paid and unpaid?
Thank you. So that was a challenging and lengthy question. And we also appreciate that some of you represent agencies that may have more to say in response to this question than to some of our other questions. So there's a handheld mic here, so you can just pass it between you with anything that anyone wants to say. So Eve is passing up the opportunity.
So it's making its way down here because Ralph and I have spent much quality time in many rooms together on this regulation. To answer the question of how the regulation can really fulfill the vision, which is my interpretation of your question. I mean, I think there are multiple moving parts here, right? It is important to remember that Medicaid funding is a state-federal partnership. And while we may not like that in terms of what that means related to consistency, it is going to look a little bit different in every state because these are going to be decisions that states make in terms of how they implement the reg. Okay, I guess I'm not eating the mic enough. Is that better? Okay. So I think one of the things that certainly HHS, CMS, ACL, and our partners across HHS are doing is working very hard with states and stakeholders to talk about the expectations of the rule and what it means when we talk about the opportunities that should be afforded to individuals who are receiving services under the rule. And states, as was explained, in terms of the current service provision in settings that are not compliant with the rule, will have up to 5 years to bring those settings into compliance. All of that is, you know, how the bureaucracy and how the rule technically works. At the end of the day, if the vision is really going to be accomplished, the advocates at the state level have to be clear with their state about their expectations. And Ralph may have a little bit different perspective on some of this, but that's how it's going to happen. It's not going to happen because we put out a really good rule at the federal level. Because we did put out a really good rule, and there's a lot of opportunity in the rule. But if that vision that you described is going to occur, it's going to occur because people at the state level are committed to seeing that vision occur. People are willing to work on a cross-disability basis because we need to remember that this rule cuts across all populations. It's not just a DDID rule. This is a rule that affects older adults. It affects people with physical disabilities. And that's not to say that all the services have to be the same. But if you are not working in coalition at the state level to implement this rule, you will not be successful. And I think that the partnerships between the advocates and the states are going to be critical. There is a lot going on in state agencies right now. There are a lot of capacity challenges in state agencies in terms of implementing these rules, and they need your help, and they need the help from individuals who are receiving services and from families to understand what you think the vision of this rule should be in your state. And that is what's going to bring this rule to a place where it actually makes that vision possible. It's not going to happen overnight. I mean, we have 30, 40 years of building a service system that I agree, many of those words have been co-opted, that we will have to continue to work towards changing. But I think the rule is a great leap forward and an opportunity for people to push those systems.
Thank you. The first thing I'd say is the rule is groundbreaking, and anybody who's been to a groundbreaking knows that you can end up with a beautiful building or you can end up with an abandoned project. And that's what this rule has started. I'm hoping at the end of this, we end up with significant settings for everyone who is here. There were a lot of different questions asked in your single question. The first piece that I picked up was, what words would we want people to use? I would want every provider in every state to think the following question: what would I like or need someday in my life? In my own life, I've had many of my friends eventually end up with a disability, eventually end up in a wheelchair, and tell me how isolating it is, how people don't talk to you when you're in a wheelchair. And any of us could be there someday. We all are growing older, and nobody knows what their chromosomes genetics hold for them. So I think the number one word is a bundle of words. It's a question: what am I going to need and what do I want? The second thing I would tell you, the word that I hear coming at us the most is choice. And it's expressed in a number of different ways, including, if I choose it, then it must be home and community based. That's a dangerous philosophy. Since 1981, individuals have been able to choose the setting they receive their services in. They've been able to choose between an institutional setting and a home and community-based setting. This regulation begins to define what home and community-based really is and seeks to stop the drift so that there's a clear delineation. We can't let that delineation be diluted by an argument that choice means if I want it, it automatically has the qualities of home and community based. The next word I would tell people they need to think about is dreaming. We are getting a number of correspondence that from individuals who believe that they can receive the services in the types of settings that exist today, or they can receive nothing. There's a broad space between those two concepts. That space needs to be filled, and it needs to be filled by the people who are receiving the services, and the push to change services to integrate fully into the community. The third word would be thinking. We got a call from somebody who will go unidentified, who wanted to know in day programs, Ralph, other than having privacy in a bathroom, how the heck does this rule apply? Particularly, how does privacy, dignity, and respect apply? And I said, well, in your day program, do you post medication sheets? Do you have somebody walk around with a medication cart so that everybody sees what people are getting? Do you allow individuals to speak privately to each other or to visitors and or family, or must they do it in a common area? When you're working with somebody on something, do you tell them about their successes or failures in front of a room full of people? Or do you do that privately and respectfully? And they went, oh, that is different, isn't it? We need to think that way. So I think those are the big words that I would tell you. The first set is, what am I going to need and how do I want that delivered to me? The second is, what do I dream of? How can this change to better serve me? And the third is, let me think about what this really means to me as an individual. If you fight for the status quo because you believe that's all you can get, that is all you will get. You have to look for what you want beyond what's there. The rule, as I said, is groundbreaking. Let's build on it and make something of it.
Okay, we also wanted to hear from Scott Shepard, who's the executive director of an agency called Avenues in California, with a particular concern, and then we'll hear from Sue. Okay, thanks.
Great, thanks, Angela. And actually, Sharon, you answered a lot of what I was going to say. So, or at least you pointed me in the right direction. And I wanted to thank Ralph also. You had done a webinar just sort of explaining a little more in detail on HCBS for TASH a few months ago. I was able to sit down, and that was really helpful. I guess my concern, and from California and with the state-by-state interpretation, it gets back to what Gail said and what you both talked about, is the interpretation word that we're a little worried about. But one of my concerns is the interpretation of the regs that risk excluding people who use non-traditional communication, especially for those people that would benefit from supported living or individualized community living supports, and especially in my state in California. Some decision makers believe that in order for a person to receive individualized community supports, or supported living as we call it in California, they must be able to voice their preference or choice to live in their own home. And they must be able to voice that in traditional ways. And that would exclude a lot of the people that I support, and as well as a lot of people who are elderly, who may have strokes, et cetera, that may impact their communication ability. This could potentially exclude, again, people with more significant disabilities who don't communicate traditionally from receiving those person-centered supports. Now, I believe from what I've heard from the Act that the from the HCBS, person-centered planning outcomes will assist individuals to receive services in a manner that reflects their personal preference and choice. So I guess I'm looking for help on how can we show this when we're working with our state legislators, and what kind of qualitative measures would be helpful to help ensure that all people have this opportunity to receive person-centered practices, not just people that can voice it traditionally.
Thank you.
No, you go ahead.
So Ralph and I are running through the rule because there's actually language in the rule that talks about how person-centered planning needs to address the needs of the individual in terms of being able to access and understand the communication, and as part of the person-centered planning process. And for that, states have no transition time. They should be doing that now, and if they are not in compliance with the rule, right, Ralph?
Mm-hmm. Yes. As of March 16th.
But the rule actually does address that, and we'll try and find the site here, and also talks about the fact that person-centered planning needs to include the supports for the person in order to participate in the person-centered planning process in a meaningful way, right? I mean, that's my paraphrasing, that's not, but the intent of the rule is to address both of those factors, in particular for individuals who use non-traditional communication. There's, and we can pull the numbers here, but it's little 7 in section 2 under the person-centered planning talks about that the person-centered plan needs to be understandable to the individual receiving services and supports, and the individual's important to supporting him or her. At a minimum, for the written plan to be understandable, it must be written in plain language and in a manner that is accessible to individuals with disabilities and individuals with who have limited English proficiency. The intent of that is that the plan needs to be accessible to the person who is the center of the plan, in whatever form that may take. So I think, on that specifically, there is language in here, and people need to delve into this and hold states accountable, because the expectation is, yes, individuals and the people they choose to have support them need to be central to these processes. So is that helpful? And then I know there's a second part, and I've already forgotten the second part of your question.
Yeah, because how can we help show this, I guess?
How do you show it to the states? So, I mean, I think going back in and pointing up the language, I mean, the other thing that has happened here is, so we have great language here in the rule on person-centered planning. I agree with your supposition, Gail, that person-centered planning, as many of us envision it, is not necessarily what people have implemented or are implementing. And even though states are supposed to be fully compliant with this, I mean, I think it would be disingenuous to say that everybody who's out there delivering services is doing meaningful person-centered planning that really does everything that we'd like them to do. We now have a guidebook on at least the bare minimum in terms of person-centered planning, not only here, but actually under the Affordable Care Act. There was language in an obscure section called 2402A in which we were also able to promulgate guidance that applies more broadly to all HHS programs, not just Medicaid funded, that again reiterates and has this framework around what does it mean to do meaningful person-centered planning, and lays down some markers. Now, implementation is implementation, and we get that. I mean, that's the variability, and that's where, again, back to my original point, advocates, individuals who are receiving services, and family members have to hold the system and the states accountable. I mean, that's how, at the end of the day, it's going to work. You can have all the pretty words in the world on a piece of paper. If you don't have people with good values in the system who understand the intent, you can't get there.
I would just underscore, and then I'll hand it to Sue, that the reg also says that the setting is integrated in and supports full access of individuals receiving Medicaid HCBS to the greater community, including opportunities to seek employment and work in competitive integrated settings, engage in community life, control personal resources, and receive services in the community to the same degree of access as individuals not receiving Medicaid HCBS. In nowhere in that definition does it say, except for those individuals who cannot communicate verbally. And I need to be clear about that.
So just don't forget, in talking about how people are going to about how people are going to communicate their wants and desires, the ADA still applies here. So it's not just Medicaid that they have to comply with. The states have to comply with the Americans with Disabilities Act, which says that they have to ensure equally effective communication with people with disabilities, all of them, as they have with people without disabilities. And it doesn't just say communication to people with disabilities, it says communication with people with disabilities, including the communications the state is getting or supposed to get from the person with a disability themselves. So 28 CFR Part 35, you can haul that out, and they have to try harder. They can't just write off a person as being unable to communicate. There is no one way to communicate, and the ADA recognizes that and requires states to accommodate that.
I know we need rules and regulations, but I always flew under the flag that says, rules, we don't need no stinking rules. And I think this is important. So we just lost the CRPD for this year again. There is a significant section on legal capacity that describes the importance of states' parties' ability to provide supports to people in decision-making roles, including the notion that sometimes, if you don't speak, it's the people who love you, who sit around you at the table, who do know what you want and what you don't want, and they must be paid attention to in the same way as if the person was speaking himself. I just want to point out a paradox. If you speak for yourself, you probably don't need a person-centered team. So if we're going to call person-centered planning the one where the person sits in the middle and tells everybody else what to do, that's not really what person-centered planning means. So here's a practical idea. You guys, if you're worried about definitions, you need to take control of Wikipedia. You need to go in there and define these terms the way you want them defined, and you need to monitor what other people are saying there and make sure that you can keep pointing to these are the community expectations of what these terms mean. And make sure you're like as radical as Tash could possibly be in doing that. So don't go in and go blah, 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 this is what the rule says. Go in and say, common understanding of people who care is that this word means this, and it does not mean that. you should be defining all kinds of words that way. But speaking as the mother of a nonverbal man, I want to point out to you that regulations regulate. They don't motivate. They limit actions that you take, but they don't put you on the right path to take those actions in the first place. So I don't know if anybody's done a research project with the 20-some thousand graduates of Partners in Policymaking to see what choices they make and what they want and how it's different. But I would say, as working in the education system, we don't do enough to reach young people and families with the ideas of best practices while they're still young enough to make up their mind about it, to not be calcified about it. And best practices, individual advocacy, and system advocacy are things that we should be teaching to everybody.
I have one more thing I can do. Do I still have 1 minute? Okay, I'll try not to talk as fast as I talk. 6? Okay. So a little bit on the issue, the key words in that question, in those questions, were words, actions, spirit, and boldness. I particularly liked boldness. It is one of my favorite words. But one of the things I want to talk a little bit about is that in the question we also referred to the least restrictive environment and Olmsted in the same sentence. Those two phrases don't go together. We all got to be clear, it's the most integrated setting under Olmsted. That's what Olmsted requires. And it doesn't require just any integrated setting. So it's a little different from the approach that Medicaid may take in defining what an integrated setting is. It requires the most integrated setting that's appropriate for this person. So I don't get to tell HHS what the HCBS rule will say or how it will work out, and there's a lot going on there. But we have tremendous hope. They hate it when I do that. But we have tremendous hope that HCBS settings rule will make more integrated settings available that people can then choose the most appropriate one for them. And it's the one that's most appropriate for them that leads to implementation of the Olmsted requirement. So that's just a little bit on the different approach that we have than the settings rule does.
Sue, is there something else about that first question?
Can I tell how much time? So in the early 2000s, I did the best thing I ever did with my son Charlie. I went to testify at the UN on the CRPD, and I kept raising my hand, and the people running the meeting, who were women out of the pain community, refused to call on me because they said I was just a parent, and that if I wanted my son to come, I should bring him and he would speak for himself. And I said, well, that would be a miracle. And then I realized that the chance for a nonverbal person to testify at the Disability Caucus working on the CRPD, if I didn't do it, nobody else was going to be bringing their son or daughter or brother or sister or loved one there. So I brought him, and his assistant who worked in the system, and his brother and we all went and testified. And I opened by saying, now please understand, there was 400 geniuses in wheelchairs in the room. And I said, you guys told me that if I wanted him to be heard, I had to bring him here. And you're writing language on legal capacity that says all people should always make their own decisions and speak for themselves, no matter what, with no legal representation from other people. And you might as well call this the UN Convention on the Rights of People with Minor Inconveniences, if that's what you're gonna do, because it really runs into the rubber hits the road when the person doesn't speak. So I said, you told me to bring my son, I'm gonna let him talk. And I stood back and Charlie looked around the room and he looked at his hand and he flapped a little bit, and it was the longest 5 minutes of my life. I felt like I was right on the edge of being disrespectful to him, which I never want to do. But I said, Charlie, tell people what you want in your life. And then I explained that I had had access to all the best communication supports and theories and everything else, and I'm an American, and I didn't have anything that worked for him, some magic technology. They all believed that there were magic technologies, that all nonverbal people could just use a computer and speak for themselves. And then I said, you know what, you guys told me to bring him and that he would speak for himself, and I think he just did, and I hope you were listening. And they added a whole section on supported decision-making to the legal capacity language, and it's there, and it's why we should be working on CRPD. If we come out of the DD community, it's one of the main reasons. Everybody says, oh, we already have ADA, we don't really need CRPD, but ADA doesn't really help us with supported decision-making.
All right, we're going to move on to our second question. Our second topic is, how can support recipients, families, and their allies be best supported by state agencies to get what they need to live the lives that they want? We're going to hear from three people at the beginning about this. So the first person is Jeff Strully, who's with the J. Nolan Community Services in California.
I dressed up for you guys. Just to make sure you know this. Thank you, Angela. Thank you for our guests joining us today. Okay, I thought I was getting another question, so I'll ad-lib at this point. I think no, just relax. We have to.
She's timing you.
Oh, really?
Yes.
Oh, that's great. We'll go with a different approach here. The question is incorrect. And the question implies, I guess it does. The question implies that you actually can deliver something that I really need as a parent or as a provider. And it's about time we have a better conversation about this, because in the state that I live in, which is California, there's an implied agreement that we have something called an entitlement. The trouble is the state of California cannot deliver some of the stuff that's really important, such as friendship, such as love, such as things that really matter. Now, you guys could beat the hell out of them. CMS could threaten with money, and Eva could look at some legal issues, and that's fun. For those of us who are providers, we enjoy when the feds come in to annoy, because you really don't beat up, but you do annoy California. And I think the part of this remains the issue of how, if we're really interested in a sustainable community, how do we figure out how to change the dialogue to one of asking the question, how to support this person to have a good life, rather than either pointing fingers or threats or lawsuits or all this stuff. If employment is an issue, then I know that that's hard work. I know it's complex. I mean, if I knew how to do it for, as Sue talked about, people who are fairly complex and trying to figure out who the hell they are and what they want to do, it takes a lot of work. I think the current dialogue we're having between state and the feds and the providers and the families and the consumers has to be changed to one of how are we going to work together to figure this out, and also recognize the financial responsibility. The state of California and the federal government will never have the money. You never will. So when you change the Department of Labor, which is a wonderful idea, except no one has figured out how we can do this, and we're going to wind up hurting more direct support players than helping, and I think that's a tragedy. So I guess I'm more interested in the question, stop?
Yes.
I see, I can read. I know my sight words. I got it. All right. So the question I just wanted to really ask is, how can we reconfigure the conversation to put us on the road of really doing what the spirit is of all this, rather than getting mucked into all the rules and regulations? I am now retiring, so the hell with all of you.
Thank you. Now we're going to hear from, thank you, Jeff, Jessica Renner, who is on the Washington State's Developmental Disabilities Council. She needs it with her iPad. Sit in front of the podium so everybody can see you. Okay.
My name is Jessica Renner, self-advocate, a client of Total Living Concept, a member of the Washington State DD Council, member of Transit Advisory Commission, as well as the Agency Council for Coordinated Transportation. My question to the panel is for people who use waiver services have to contend with a wide variety of service options, such as keeping track of waiver requirements, Section 8 housing, live companions, state rules on supported living, plus my medical needs is to say the least complex. Waiver participants, such as myself, need easy to understand and use versions of rules that are typically not written with us in mind. That is, how do I know what I am promised if I can't easily keep track of all of the supports in my life? Why can't federal agencies provide versions of rules in various formats for the use of participants?
Thank you. Thank you. You guys got that okay? All right, and then we have one more person to present comments or questions to you also, who's Lyle Romer, who is the Executive Director of Total Living Concepts, which is also in the state of Washington.
Instead of answering,
We did, yes.
Okay, all right,
We did.
okay. Well, thank you for the opportunity to pose a question to our panel, and thank you for joining us today. My question is a little difficult to phrase, and I think it's going to play off of a couple of other people. When we read the rules, the new rules, we hear a lot about access, and we hear a lot about physical environments. And when you read the rule, the only place that I find statements to the contrary, not contrary, but expanded statements about people's social relationships is in the section on person-centered planning, okay? So my question may be a little baffling, it is to me, but as Wendell Berry says, a mind that isn't befuddled isn't engaged. So perhaps the more I befuddle myself and you, the more progress we'll make. But the most important aspect of life for every person sitting in this room today is our personal relationships. After carefully reading the CMS rules, I think there's only one place where social relationships are mentioned, and that's in the section calling for each person to have a person-centered plan. The waiver participants are to be in charge of who is invited to assist the person envision a desirable future, identify necessary support to move towards that future, and make changes based on those results. The plan is to form the basis for meeting the person's desires and needs to achieve a fulfilling, purposeful life. Freedom of choice is paramount. Relationships are crucial to success. To truly implement person-centered supports and create opportunities for relationships, for people to form relationships, people seeking and offering support have to work within a framework of ever-changing challenges, personal preferences, and all the triumphs and disappointments of life. John O'Brien sees partnerships between people seeking support and those offering. He says partnerships define, negotiate, acquire, update, and improve the means to create and sustain people in contributing roles in work and at home as their life circumstances change. These partnerships are a study in constant innovation. I'm reminded of a simple little book from the 60s written by Fritz Schumacher called Small is Beautiful. When people have the freedom promised in these rules to author their own lives with supports customized as needed, where this will take us is completely unknown. We don't know where this is going. What will people need in the way of supports? What will they need when we open up to the choices that individual preferences that are promised that people will work towards? And how will they get there? There's no simple measurement issue here. This is a real challenge to support relationship building without the destructive interference of well-intended, yet nonetheless premature and imperfect means of documenting success. We don't know a whole lot. We know they're important, and we don't know a whole lot. There's no task analysis for social relationships. And my question, I think, goes to the fear of some of us who try very hard to work on our person-centered practices, that something as crucial as social relationships is in no way ready to be measured, to be counted, to be weighed, but to be truly valued for what it means in people's lives. How do you suggest we continue the work when we're constantly having the intrusion, sorry, but it is intrusive, some of the documentation that must be provided? Two things can go wrong with social relationships. One, we can try to apply our simple measures to that realm of people's lives, and that would probably destroy what we were trying to do. Second, we can ignore it. And one of the things that I fear is that we'll be forced to ignore social relationships because we're paying so much attention to all the other things that we have to document. So, how are we going to grow the absolutely crucial and necessary social supports of people and not be burdened with premature and imperfect ways to measure, to document that we're doing something that we're still learning how to do?
Great, thank you.
So I hope I've baffled you.
Good, thank you. All right, 3 radically different questions.
So, 3 radically different questions, and I'm just going to drop some non sequiturs. So, for one thing, I don't agree that the absolute end of all of the work we do is that we get to say nothing about me without me. What I always used to tell my son is, and just remember, honey, not everything is about you. And I think one of the problems we have is in our gut. We don't like the idea of using Medicaid money to build a good life for an individual person. I think we need to start thinking about how do we do that in the context of a family and a community? And how do we use those services and supports to enrich that context? And I think that gets us a little bit towards social relationships. Plain language is important not only for people with disabilities, it's important for bureaucrats also, who frequently spend their lives dancing around tied up in knots with regulations. When a long time ago, I was able to fund a project called the desk.info that took states' Medicaid regs and put them up online in plain language, and it was run by self-advocates with support. we found out that the most users of it were people in state Medicaid agencies who were trying to figure out what the hell their rules said. So I'm just going to say that and say plain language, I think, is a commitment that we all need to make to everybody at all times. And this may sound weird, but I think one of the answers to the measures you're talking about is if we could make peace or begin to understand ethically how we could use big data. We think we have big data, but we just have a shitload of data. Pardon the French. We just don't have, big data is little bits of data that are collected in natural ways throughout the day, and that the person whose data is collected doesn't even know that their data was collected. So a sensor in a bed that tells you if somebody was wet all night long, or a sensor on the door that tells you if somebody left their apartment or had friends in their apartment. We have to think through the ethics of that. What does it really mean? Do we want Big Brother and big data spying on people with disabilities? But there are trade-offs. And we already know that young people in general are willing to give up some privacy for better service. And why wouldn't that also apply to some people who have disabilities? If we really could say, look, we're going to be measuring things and tracking as we go along. And I'm not saying I think it's the answer. I'm saying I think we need to evaluate whether it makes a contribution. And then we need to start to build data systems that actually do what we want them to do in human services, because our current systems are just accounting systems. That's all they are.
So kind of jumping around a little bit on the questions, I think starting with the question at the end around data and social relationships and how do we measure what matters, right? I mean, and as one of those bureaucrats who's spending time tied up in knots around this question in the context of Medicaid funding, we have a substantial conversation going on around what is quality, right? I think we don't want quality to be defined by choice, because that's a slippery slope, right? Our friends out in the world who are advocating for some very old notions of institutional settings and gated communities and segregation are arguing that that's choice and that can create quality. So the downside of not getting into the data conversation around what is it we mean that when we want to measure what we're doing and what matters is that if we don't have that conversation, it may be defined by things that we don't think are important. Right now, a lot of those things are process things, right? When you look at what we require of states in terms of assurances in many cases related to the waivers, and when we look at what's happening relative to the national quality strategy and the kinds of measures that are getting looked at, often they're process. They're not, do you have social relationships that are unpaid? And do you spend time with anybody besides family or people who are paid to be with you? Right? So those are things that we need to figure out how to get to without ruining them by making them clinical, right, 150 pages of regs. But if we don't have that conversation, they won't matter because they won't count. And as managed care, I mean, it's like, you know, right? So if you look at the complexities of what's going on in many of our states, managed care is coming in, right? Managed care is going to be the entity that determines under this pile of money, what are we buying? And if we can't say part of what we're buying is important to us in a way that they can understand it, we won't be able to buy those things. So it's a dance, and I think it's one that we're still figuring out. Actually, on a real bureaucratic level, we are in a process that's just starting tomorrow, I think is the first webinar, in a partnership between HHS and the National Quality Forum to begin to talk about what is the framework for determining quality in the home and community-based services space. What should it look like? What are the domains that we should be talking about? CMS has made a run at this multiple times, but we actually now have some energy behind it because of the Affordable Care Act and because of the requirement for a national quality strategy. And I'm happy to go into the weeds on that with anybody who wants to after this session offline. I don't want to take a bunch of time on it. But those conversations are taking place at the federal level, and there will be an expectation at some point in the next 2 decades from payers around when we are buying home and community-based services, what are we buying that's of value? Which is fundamentally different in terms of developing an evidence base and how we want to talk about that from, when we buy a diabetes management system and an intervention, we know that this is the evidence base that's been established in a clinical setting that allows us to demonstrate that that intervention is better than this intervention over here, and so this is what we should buy. How are we going to do that when we're talking about Medicaid money? Medicaid money is health-related dollars. We have to figure this out. The other thing I want to say just really quickly, because I know Ralph's dying to get the microphone, is the question of how do we change the conversation? Actually, Barb and I were just in a room the other day with a bunch of the advocates, the DC-based advocates, debating a similar question. I think we have to fundamentally change the question. Far too long, and I agree with Sue in terms of partners in policymaking to some degree, as a product of partners in policymaking, I think we have to fundamentally change the conversation with young families. From what do you need and how do you advocate for it, to what do you dream about and what's a good life look like? We spend way too much money, time, energy, as evidenced by the question from Washington State, on managing systems, advocating for stuff, and assuming that the service system is going to solve everything, instead of saying to families, there is going to be a mix here. In order to have a sustainable system, sometimes the service system is going to help, and guess what? Sometimes it's not. We don't have those conversations with families. We have, I'm going to say it, many people in this country who are overserved at the cost of people who are then underserved. We have no rationality in the system in terms of how the resources are allocated. And the IDDD community is afraid of this conversation. Because guess what? There will be winners and losers. But right now there are winners and losers. And we do not have a conversation about what does it take to have a good life. And we do not have a conversation about how do we support families to dream. Right now, through ACL and AIDD, we are funding resources in a half a dozen or so states who are looking at this question, who are trying to change the question from what is it that the service system can do for me to what do I need to have a dream and what do I need to do to have a good life. And that is an absolute different framing. And I think we have to do that, starting with our Birth to 3 Part C programs, going all the way up through our AAAs as people are aging. And that's the framework that these community practice supporting family states are looking at, is how do we do that, and how are we going to do that in a way that we're talking about meaningful community integration and inclusion, because if the rest of the community doesn't participate in this, it also is meaningless.
I have a couple thoughts. Number one is this. I did investigations for 5 years in the course of my professional career. I developed a greater respect for regulation than I ever had prior to that. Regulations don't just dictate for the best who feel that they should not have to document services, but they dictate for those who don't document services because they don't deliver services. And that is a problem. And it's an important problem. I agree, even when I read the question, how can support recipients, families, and their allies be best supported by state agencies to get what they need to live the lives that they want? My response to that was, I don't know, you tell me. And And that's one of the things the rule tried to do through the transparency requirement for both the transition plans and for waiver amendments and renewals where there are changes, substantive changes as defined by the rule. They must go out for public comment. That question has been reversed. People are supposed to tell the state what they need. If you feel your state doesn't have a clue, it's your opportunity to give them the clue. So the other piece of this I want to make sure people understand is this regulation went through 5 iterations. It went through 4 NPRMs and an ANPRM. This is the least bureaucratically developed rule that I have ever seen. I got this job and ended up having to respond to questions I sent in. Which is really a difficult thing, guys, I gotta tell you. Why did he ask that? Why did I ask that? Okay. So a lot of the shaping of this rule came from the people in this room and people like you. And it's important to recognize your power and what you've done, what you've achieved, and what you can achieve. The other thing I would say is this, with regard to a social life and having individuals in your life. The bottom line is person-centered planning builds on that. But the first principle of settings is that it's integrated in and supports full access of individuals receiving Medicaid HCBS to the greater community, including opportunities to seek employment, work in competitive integrated settings, engage in community life, control resources, and receive services in the community to the same degree. I defy anybody to tell me that people who are not receiving Medicaid HCBS do not have social lives. This rule requires people to be allowed to build lives just like everybody does. Social interactions and social relationships are vital to people. They are what move you forward. And there's, in my opinion, everything in this rule to support that concept, and to support that concept beyond paying somebody to be your social network. It's to build a social network of people who care for you and who you care for, that you don't have to give $1 to be there.
Alternatively, I have a good friend who works in a very, very responsible position, who has a PhD. He likes to come home from work when he's not traveling and watch TV. And then on the weekends, he likes to have dinner with his family. And his brother, who has epilepsy and developmental disabilities, likes to do exactly the same things. And everybody is always trying to write a plan for him, or he goes out bowling at night, or hangs out with people, or does other stuff, and he wants to go home and watch TV by himself. So this is really important to figure out, what does social mean to each person? And it's different for each person, and sometimes it's different at different times of the year, or in different moods, or different days, and so how do you build that flexibility in? The other thing about a person-centered plan, though, is it's really not a thing, as I understand it, it's not a planning process that a bureaucracy uses to allocate services. It's a planning process where people around someone who care about him or her come together to figure out, what can they do? What can everybody bring to the table? Not just what can we get out of the public funding cookie jar, but what can each of us bring, and in unpaid ways as well as paid ways. The last thing I want to say is, I think there's a relationship between what you guys were just talking about and most integrated setting, and I think it's a mathematical relationship. If you put freedom on this, if you put dollars, budget dollars on this axis and freedom on this axis, and you start out, and the more money you get, the more freedom you have, right, as a person with a disability. And then you reach a certain point where the more money is allocated to you, the less freedom you have. That's the point of most integrated services, or least restrictive setting. That's the point where we have to be seeking that for people, and pushing it, trying to help people understand, hey, you're more capable now of being connected and doing stuff than you were last year. So, yay, you get to give up a little money. That's a hard conversation to have.
All I do is sue people, so not a great way to build friendships for anybody. But I often now talk about, yeah, exactly, I won't sue you, I promise. But I often talk nowadays about why hasn't, so we're getting people out of institutions, 46,000 so far, and why hasn't that just taken over like wildfire? Why are people still saying, no, my child should stay in the institution, why should I want to stay in the institution, or so forth? And I say, well, that's on you. I'm not that nice a person, but we need lots of nice people who will just step up, say hello, and incorporate people into their lives. And this is the same way, don't lose hope, this is the same thing that happened with other civil rights movement, and for me, this is a civil rights movement. The civil rights movement could not make black people and white people be friends. It couldn't make men and women go to the sports event, any sports event, together. But what happened is, and continues to happen, is that the more people were in the same places, so we can make the employer hire you, and we can make the sports arena let women in, and we can make those things happen, and the more we all show up together, the more we build those kinds of friendships. It ain't perfect, God knows. The Leadership Council for Civil Rights will explain in all the ways that has not happened perfectly, and I can tell you the women's ones. But that's what we need, is people to step up and be nice. It ain't rocket science, and you can't pay people to do it. Boy, am I deep.
Great. All right, we have a we have a third question on a important concern, which is that the concerns about abuse and neglect of people and the concerns about fraud. So are these concerns overpowering good practice? And we have two people who are going to speak on that. The first is Pat Fratangelo, who's the executive director of Onondaga Community Living in New York.
Okay, thank you, Angela. I've been talking all over this conference about all kinds of concerns I have. I do sit on, I have the governor's appointment on the Olmsted Council, and I totally agree with the HCBS waiver. So I agree with both things, okay? What I find is that people are now being encouraged now more by their state governments to have a more inclusive lifestyle, and I applaud that, I really do. Due to regulatory base being now more aversive to the abuse and neglect, and that's happened in New York State, the New York Times articles, they are very sensitive to abuse and neglect, fraud, whatever. There's now layers upon layers upon layers of regulation that come in. And it's all with the pretense of keeping people safe. I believe that there's physical abuse, okay, but there's also bureaucratic abuse. And that's my concern. I really think that some of what's happening is really getting down into the soul of what it is that keeps people's lives meaningful. We have excessive fire drills that are numbing people to any fire possibility in New York State. We have, Ralph talks about the status quo and earlier today. I believe that what is happening right now, at least in New York State, is that they're trying to regulate personalized services in some meaningful way, and I do understand when you want more to happen, there has to be some consistency in standards. But what you have is coming is more of a homogenized nothingness. It's really not person-driven, person-focused lives. So, for example, I just got an email the other day, 3 weeks ago, that it's all about conflict of interest. I don't have any issues with conflict of interest. I think, we should have something in there that says there shouldn't be conflict of interest. But what's being mandated right now is that no person can get service coordination, brokerage, and services from any one agency. Now, lots of people get all kinds of services from all different agencies. A few people do get all services from one agency. We don't mandate that anybody get all their services from us. But the reality of this particular rule is that you're going to tear people apart that have had 10, 12-year relationships together. And now there's going to be a stranger in their life taking over on that role. I think it should be more about, we need to ensure that agencies don't own people, that people do have the opportunity to choose who they want to be in their lives, but then agencies need to document the choice opportunities that are given to people so that people really do have people in their lives. I've heard things about, the smart house sorts of things, not allowed in our funding mechanism, okay? People can live more independently if it is allowed. I mean, it's just crazy stuff. So I guess my question is, since I don't disagree with Olmsted and what that says, and I don't disagree with the HCBS waiver and what that says, I guess what I'm disagreeing with is my state's interpretation of all this stuff. And so my question to you guys is, what can the federal government do to ensure that the spirit of personalized supports don't fall into the hutches of what I would call, bureaucratic abuse, neglect, protectionism, all of those things that I see happening on a day-by-day basis.
Thanks. Thank you. And then we also want to hear from Joe Wykowski, who's the Executive Director of Community Vision in the state of Oregon, our other coast.
I'm used to being last up with a name like Wykowski, I'll just be honest. All through school. That's all right, that's good. Get a chance to, and I appreciate what Sharon said earlier about federal policy really and Medicaid and CMS and how states have to actually do their work within their state, especially in accordance in Oregon. So I've got a couple of thoughts and questions. The first is, we often find that a state's administrative practice, due to liability and legal concerns, overrides the opportunity for freedom and choice within one's own home. And we've had 25 years of experience with this directly supporting people. So how do we clarify the concept of the least restrictive environment or the most integrated setting so that states are not permitted to turn an individual's home into a licensed program? And it only takes a minute to walk into someone's home to you can have a one-person licensed program, or you can have your own home. You can feel that pretty quickly just hanging out with someone for a little bit. And I think we've come a long way there. People's homes used to be licensed because there wasn't even thoughts at first of people having their own home, and things have been interpreted more broadly, but we're still struggling with things day to day, like people who have started their own businesses who we've assisted, and we wind up being held accountable when they lose some of their inventory or that type of thing, and as support agencies to pay for that and make up the difference when that's a real business risk. That's life for all of us if we start our own business, or we go to bat over people's needs and wants for alternative health care, where we all might go and see a natural path in Oregon or such, and an individual has to make a real justification for that because it's not a regular doctor that they want to see or that type of thing. And sort of a second part of this is, are we afraid of failure? Are we afraid to allow individuals experiencing a disability the opportunity for a real life and the dignity of risk because of the funding system's fears over the possibility of abuse, neglect, and fraud? And can our systems really protect people, or is it really the close relationships that protect individuals from harm? And those are both, non-paid and paid. Lyle worked on a wonderful paper with Pam Walker around long-term relationships of people who are providing support to people. And so those close relationships that maybe protect people and not systems. And just a couple other thoughts. We've just kind of created a continuum. I hate the word continuum, but we've created this continuum of freedom for people and control, because we find that people who are able to speak for themselves more readily and to have family members or loved ones or someone in their corner that will go to bat for them, they kind of get what they want in terms of not too many restrictions, but then others get restricted by rules and regulations, so it's not a real level playing field. And just a couple others in that vein, because we have multiple waivers, we often find that rules and regulations don't get applied to people equally, and although they're living in their same home. So I'll end there because I'm getting the sign. And thank you.
Thank you, Joe.
All right, Ralph. Go ahead, Ralph. You can start.
This is interesting. I'll start with, I think, a very bracing statement, which is this. There is federal and state dollars going into the funding of the services. There must be some type of oversight, and there must be some type of understanding of what is being done in the individual's life. We can't pretend that just because everybody's good, nobody's ever going to be hurt. There are reasons for protections, and there are reasons why, in fact, it feels like regulations are different for different people in the same setting. If it's applied properly, person-centered planning means that each individual's life in a same setting will be different based on that individual's desires, that individual's needs, and that individual's dreams. And that's an important thing to remember. The regulation should be broad enough and specific enough to allow for that and to ensure it. With regard to whether health and safety is suffocating the ability for an individual to enjoy their life or to live a meaningful life, I don't know how you live a meaningful life if health and safety is not a concern. From the other standpoint, the regulation clearly states that risk should be addressed. Any measure to mitigate risk should be addressed. It doesn't say an individual must live a risk-free life. In fact, it does not say that at all, nor is it implied. Individuals should be allowed risk. But there is a difference between risk and a guarantee of harm. And that's an important consideration. And again, there's a piece of me that's answering from 5 years' worth of investigations, folks, and I have to be clear about that. I've seen the best, the absolute best of services, and I've seen the worst. I've seen people develop brilliant and beautiful lives for themselves, and I've seen people hurt, truly hurt. There's a balance here. Sometimes that balance feels like it infringes. Sometimes it may. And sometimes it may be the only thing that ensures that somebody is not abused or exploited. So I think that when you're thinking about what you have to do, and Sharon's going to have a better statement about, I think you're going to talk about the measures. She'll have some information for you that'll help flesh this out, but there are many ways to ensure that an individual has a safe and good life and a fulfilling and rewarding life. And I think that we need to think about that and not simply say that oversight is bad, it's wrong, but try to understand what it is, and if it can be shifted in a better manner, then do so. Look at the right measures for that type of activity. Sharon?
So back to the quality conversation. I think that at the end of the day is going to be part of this issue, right? So if we want to talk about what is important in the provision of services, inherently, as public funding, health and safety is always going to be pretty high, and I don't know that there's anything we can do about that. I mean, I'm not saying, and for those of you who know me well enough, you know that I'll stand up in a room and say that, you know, dignity of risk is equally as important to health and safety for all of us as human beings, inherently. When you're talking about public dollars, there is going to be a level of accountability related to health and safety that is that's unavoidable. I think the way that we begin to balance it out, and I think that states right now, what we've done is we have a system where we have, you know, 51 different entities across the country who all decide in different ways what that means and what that is and how we're going to measure it and what's going to be important in our state framework and how we're going to talk about outcomes, whether it's related to health and safety or whether it's related to social isolation. And part of what we're trying to drive towards is how do we at least begin to understand and unpack that on a comparable level and what is important to people. And there are lots of different ways to do that. You know, we now have 42 states that are involved in the National Core Indicators for people with intellectual and developmental disabilities. That is systemic measures, but we also are starting to see states look at that and say, wait a minute, how do we oversample that and begin to look at that as an understanding that tells us not only are people safe and free of abuse and neglect and happy with their services, what do their families think about it, but do people have relationships that are not paid? If they're interested in employment, are they being supported to pursue employment, you know, across a set of domains? So I think that getting back into that measurement conversation, which I know is highly unsatisfactory when you're sitting at the state level and you're trying to make these decisions right now, is the long view. I want to go back to something that the first question around the conflict of interest issue. It is actually the federal interpretation that entities cannot be service providers and be the developers of the plan. That there has to be a distinction made there, and that is intentional. The intentional decision, and we spent many hours debating this, knowing exactly what you're talking about, because sometimes those trusted people are the people that you want doing this, who also then want to get paid. There is we have way too many investigations, way too many situations, and we were not able to find a way that we could not make this black and white. You either get to choose, you get to be a service provider, or you get to drive the person-centered plan. Now that doesn't mean you don't get to participate in the person-centered plan, but you cannot be the person, the entity who is responsible for the legal document that is the plan of care, which may be different than the person-centered plan. But bottom line is, if your plan of care, your legally enforceable document in terms of your services, is developed by your service provider, that is in violation of the rule. Okay, so that I do want to be clear on, and that is a conflict of interest provision that was very important in the conversation.
Okay, I'm going to start with, that's one of the things I referred to earlier, is that people are you can't be of the understanding that it is what exists now or nothing. People are going to have to develop the skills to do this. Certainly, a person-centered plan means the individual is the major thrust of the plan development. The person developing the plan is the person who also is working with the individual on the assessment and is also working with the individual on the choice of providers. There is inherent conflict. If I am the person developing the plan and working with the individual on the choice of providers, and I am the provider they are choosing, how does one establish that that choice was made free and clear and not related to or developed on the relationship of the individual to the person creating the plan? I need to be clear, though, that does not mean that the service provider does not have input into the plan. That is exactly the wrong way to work this system. If I am going to be purchasing a service, and I'm going to go way off topic here and tell you that if I'm purchasing a service from a mechanic, you can be sure that the person who's my insurance coverage isn't the one dealing with the mechanic and finding out what they're going to render and how they're going to do the service. It's going to be me. But I do have somebody who's working that piece of it and ensuring that I'm covered and that I had choice. And that's not that different than what we're talking about here. If you do the service plan, you are working with the individual on the choice of the direct service provider. Offering yourself as the direct service provider generates a conflict of interest that I don't see a way around.
So quick, I think sunshine is really important. I think having different organizations talk to each other is really important. The point of, I think, a lot of sunshine laws is to create conversations, and I do think that's where human responses come from. So it is hard, and it costs more, and it's the right thing to do. Vulnerability related to smart houses drives me nuts. So one of the things I was trying to do with my son before he died was get rid of his awake overnight staff. He and one of his roommates were each rated for awake overnight staff. We managed to combine those into one awake overnight staff. Then we tracked for 3 months, when did the awake overnight staff ever do anything? And the only times that the two guys were awake during the night is when the awake overnight staff woke them up. So, but trying to replace that with monitoring so that the asleep staff downstairs could come up and do something was like pulling teeth. And I finally just said, do not tell me you can't serve another family with 8 hours a day of staff time. Do not tell me you can't take somebody off the waiting list with that. And I just think we have to start thinking bigger about some of these things. It's not just the benefit to the person, but also the benefit to the system of trying to think more broadly about risk. I want to put on the table that I think some of this vulnerability stuff is historical in its root, and I think, you know, in the bad old days when states ran state-only dollar, group homes and sheltered workshops, there were congregate decision-making about who was in there and how were they served, and when states decided they wanted that Medicaid match and pushed all of those people onto Medicaid, we got a lot of people on Medicaid who all of a sudden got better lives because the values that came out of the Medicaid program were a lot better than what was being delivered in most states or many states. But by the same token, we also got a whole bunch of people into the Medicaid system who didn't used to be there. So it used to be a system constructed for people who were pretty significantly vulnerable. And now you have a whole bunch of walking, talking people coming in with less vulnerability because they have more capability of explaining, I don't like that person and here's why I don't like them. Or I don't want to do that and that person hurt me. And the people who were served under the old ICFMR standards tended not to be those people who could self-report so much stuff, I think. So I think we haven't really looked at the historical changes as we pushed everything onto Medicaid and what has that meant. And we've centralized federal rules without really creating a national program. And you guys know just as well as I know that it's the institutional settings that should be waived and the settings in the community that should just be funded. But we're not really looking at these big, chunky historical moves. And I do think that it is a topic of conversation that would be fruitful.
I guess the other thing that I think is a driving force, kind of building off of what Sue was just talking about, is we also haven't modernized or talked about decision making in a way that's consistent with our values in most states, right? I mean, to the point around the CRPD and supported decision making, we've not built legal structures in most states that support individuals to make some of these decisions and to keep themselves safe. And we also have not had the right conversations with the next generation of families around what this means. And this goes back to what I was talking about before, that you know, I mean, I've been in meetings, and Joe, this will sound familiar, right? When we sit with the families who say, okay, we're all gonna come together and we're gonna build our little, whatever it is, village or gated community or whatever, so that Johnny and Jane can be safe, you know, after I die. And another colleague of ours from Oregon used to walk into those meetings and say, well, then you better plan on living forever, because there is no such thing. And if we don't begin to have, again, a different conversation, if we don't begin to look at how do we ensure that people who can make their own decisions are making them as early and as often as possible, and those who need support have legal mechanisms to be supported in making those decisions without inherently taking away their right to express volition, we're not going to get there. So one of the things that we did recently that I'm really excited about, and Jonathan, I think, left. Jonathan Martinez was in the room a little bit ago. But we recently just established a national center on supported decision making. We're now a big 2 months in, so we're not quite off the ground yet, but that Jonathan and the folks at Quality Trust, along with Mike Weimeyer in Kansas, and several other organizations, including the American Bar Association, are helping us with to begin to really try and change this conversation and talk about how do we get to legal structures that keep people safe, but allow them a higher level of freedom in their legal decision making.
And I was going to tie two questions together and say, in recent discussions with ACL and with some professionals in the field, one of the things that was of extreme interest is the value of social relationships with regard to health and safety. People fought to keep their family members in institutions because they felt they were safer there. And when they got into the community, the studies and the satisfaction surveys after the fact showed that they were much more satisfied and felt much safer and felt that their welfare was more attended in the community. The more eyes you have on you, the more ears that hear you, the more people that see you and care about you, the better you are protected, just as I am. Believe me, I have family members who call me up to make sure I'm okay. I work in Baltimore, I live in New Jersey. There are people who call me on a daily basis to make sure everything's all right. That's a social relationship that's important. I have friends who want to see me on the weekends when I go home, and they will tell me if I'm looking haggard or not, and if I'm doing too much or not. All of those things are of value, and if you're looking for a measure of social relationships that measures the success of them and what they do, I think you might find a correlation to better safety and health outcomes for the individual.
Okay, we have a few minutes. If anyone wanted to ask something or bring up another concern, either in response to these particular comments and questions or on another topic. Yes, please.
The regulation does not require a state to pick specific services to include in a waiver. It has never required a state to pick specific services. Having said that, I certainly would not limit or devalue the importance of assistive devices for an individual. It certainly is an available service for a state to add. And again, I would point to states will be putting out their waivers for comments. If you see a service missing, and I'll go back to Sue's statement about when somebody's getting a service that's not needed, somebody else is going without a service. It seems to me that in many ways, assistive technology and assistive devices and equipment take the place of a more costly service. And it's a much wiser course for a state to say. But I can't tell you that this regulation dictates specific service requirements.
Great, thank you. Yeah, Barb. Why don't you stand up and project, Barb? Okay, great, thank you.
At the risk of being Captain Obvious, which is what I said earlier, I think what's true in our network is that the people that spoke today are really sort of the best of the best. If you wanted to put on a rubric who's delivering personalized, individualized supports the best in the nation, you've just seen them. And they have some colleagues out there in the universe, I don't know how many, it's kind of hard to measure. And many of these people are the only people in their state, the only agency. All of these people today were from different states except for Jeff and Scott. And so the anxiety that we have, or the concern or the worry, is that the new regulation, which we love, and we're a big part of submitting the original comments for, and we just want to say how courageous it was to issue those regulations. We're thrilled with them. But we're so worried it's going to be bastardized by the same well-funded legacy organizations who have big policy staffs and provider agencies at the state level. And that's a deep concern that we have. And so, and I don't mean to be so mean, I mean, there are good people doing what we know are services that they value, and we wish that we could help them come along.
So, do you have any advice in that reality?
I don't think this is unique to HCBS, right? I mean, I think when you look at healthcare broadly, it's a financing issue question that's being played out across the whole sector, right? It's not just us in this space. It feels really, really personal to us because it's longevity and intimacy, and I think we can all tolerate when we have to go to the big hospital and we know that it's for a day or two and we don't want to really know all what's behind the big curtain in terms of who owns what and what happens. But when we're in this space, it's different, right? I think, again, there's real opportunity in the rule to build coalition at the state level with the folks who care about this. And I'm not saying it's easy. I get it. I've gone from living in Oregon to living in Virginia. Enough said. It's not easy. I think the other thing that I would say is that if you think as small, independent, more progressive providers or the people who are doing the best work in the country can come forward and show us the best examples, we are happy to hold those up. Some of you may have even heard from our staff in the last couple of weeks because we're in the process of compiling some of that. And we can model that behavior for people. If there are specific things that we can do that will then assist in terms of the mechanisms that we have at the federal level, which are technical assistance, guidance, information, that are specific, please let us know, and I know you do, what we're doing that can be more helpful on those fronts. But I mean, I think this is it's gonna be slow and long and iterative. I think the other interesting thing that's happening, and we're starting to see this in New York, and not necessarily all in the best ways, right, is that like-minded providers are coming together and trying to figure out ways to form networks in order to operate in the managed care space. And I think that TASH and the people who are associated with TASH have potentially a unique role to play in thinking through how does that get supported, and what are the best business practices that you want to see that then can become systemic and can be scaled up. So for example, I know that there's the New York Community Foundation or Community Trust just recently funded a group of providers to do that work, to build their own network. Our providers who are associated with TASH, who tend to be the more progressive providers as you've described it, Barb, thinking about those things, because I think to not think about those things is to put your head in the sand and not figure out how you build on the strength of the values and the network that exist in a way that can take on some of those bigger interests.
Great.
And what I would say is this, it's the same thing we said when the NPRM went out and we had people talking to us. If there's something good you like, make sure you comment on it and let people know what you like and what is positive. Don't wait for the negative to make your voice heard, because there are other people who are looking at what you might consider positive that consider it negative, who certainly will make their voice heard. So don't wait for the bad to happen to say it's a problem. When you've got something sitting in front of you that you like and that you believe should be interpreted a specific way, make your voice heard. That's the best I can say.
I have let's not call it advice. I do not give legal advice. And this is not from the Department of Justice. It's from the experiences that I've had in a variety of different contexts where I had groups who disagreed with me on everything. So I ran a nonprofit disability rights organization for a while. And we argued with the Chamber of Commerce all the time. They disagreed with us on everything. So I joined them. They continued to disagree with me on everything, but I got a vote. And every single one of them had to listen to me, many of whom were not the leaders who were the ones who were arguing with me. Made a big difference. Similarly, within the federal government, periodically there are agencies who don't agree or don't get what we're trying to do. So we send them details, people who go work for them for free. And then we bring their people here and have them with us. So my advice is infiltrate.
As long as we're giving unsolicited professional advice. The marketing advice to this is, if you're the only person in a market who's delivering a particular service, you really have to evaluate whether your service is worth putting out there. Because if it's really worth doing, you will have competitors. So build some competitors. Use your power in your state to help create other agencies that can do really good stuff too, A. B, I believe that young parents of children with disabilities are severely under-researched. So you need to understand the demand patterns of the future and what these families will be asking for. Reach out to them when they're young. Go to your PTI. Offer to do some training for them on, adult services and what does it look like, or home and community-based waivers for teenagers, and what does that look like? And listen and understand what it is they want and try to build those services. This is a tough thing to understand, but sometimes when you're out there and you're the only one in the state doing something, it's because you serve all the early adopters. You serve the people who are willing to suffer under trying to figure everything out for themselves. The people who sent away for kits and put their own computer together in the 1970s. Sometimes that's who's at the bleeding edge of human services, is the people who are willing to just put their whole life into figuring out how to make something work. And the general scope of people are not willing or able to do that. They don't have the time, they don't have the attention, they don't have the skill, they just aren't going to rise to that. So we have to figure out a way to deliver really good services to people who are not early adopters. And that's a really interesting marketing problem and something that I think we can be thinking about. A lot of the legacies were set up in the first place as provider agencies being served by groups of families who came together to put services together. And they've morphed into Death Stars. But I didn't say that out loud. Did I say that out loud? But they have put thought into how do they reach people, how do they market to people, what does that mean, how do they listen to people, and or they have created a presence in a community that just gives them visibility and people feel they have a relationship with them. And we need to go in and build relationships with families that are better and stronger and more valuable than the poster or the billboard or the fundraiser, whatever that is.
I'm sorry, we're almost out of time, and I know there's a couple of people that have more questions, and I'm sure, you guys hanging around for a little bit? Some people have to leave, but I'm sure that they're open to questions, and some of you are going to be here tomorrow, yes, on more. So they'll also be here tomorrow in terms of the another open forum tomorrow. I wanted to let people know what's going to happen with this. So there's two particular directions in terms of following up from this. One is that this whole session would be turned into a white paper, which Michael Kendrick has offered to actually write, one reason that we've been recording today. And the other thing is that based on our conversation at last year's TASH about what does person-centered mean and what does community mean, and the town hall today, looking at a future issue of the Connections magazine, a special issue of the Connections magazine, which TASH puts out about these topics, and more content and also more material about these particular topics also. Yes, question?
I'm going to invite feedback from these people. I really liked this format. It was a lot livelier than Talking Heads, and
Yes.
I think you should keep pushing on that and
Right.
trying to figure out how do we get to hear from you more.
Yes. I actually wanted to acknowledge that also, Sue. Thank you about the dialogue being really valuable. And I also just wanted to, well, thank you all for coming. And I wanted to acknowledge the size of the vision, and that it's a shared vision, and that there's a real partnership in terms of moving from what's the vision to really having it happen, and to really having it be real, to having it be true to its intentions. Takes many different parties and many different roles. That whole complexity of how do we, with all the various things mentioned today, the challenging things about friendship and love and being healthy and safe, as well as accountability for money and what can rules do and what can't they do, and that's like enormously complex future we're facing. And we're looking forward to seeing the next 5 years unfolding, especially about these rules, but also the many other directions in the next that are going to be happening in the next few years and on into the future. So thank you for the dialogue. We hope it was valuable and useful for everyone. And so thanks for coming. Oh gosh, we didn't even mention sex.